Welcome to Oncoverse, where we simplify oncology pharmacology one drug class at a time. Today we're diving into a fascinating group of chemotherapy drugs, antibiotics used to treat cancer. Unlike the antibiotics you might take for a sore throat, these are cytotoxic agents, originally isolated from soil bacteria and now repurposed as powerful anti-tumor drugs. We'll explore how these unique medicines work, the cancers they target, and the side effects every oncology learner should know. Let's get started on this journey through the world of anti-tumor antibiotics. At the end of this video, you'll have a clear understanding of what anti-tumor antibiotics are and how they differ from the antibiotics used for infections. We'll break down the major drug classes including anthracyclines and chromomycins and explain the mechanisms behind each. You'll also learn about their key clinical uses, the dose-limiting toxicities that require careful monitoring, and the latest guidance on cardiac monitoring. This foundation will help you appreciate why these drugs are both powerful and potentially risky in cancer therapy. But what exactly are anti-tumor antibiotics? These are compounds, mostly discovered as natural products from Streptomyces bacteria in the soil that have been found to possess anti-tumor activity. Unlike traditional antibiotics which fight infections, these drugs interact directly with DNA and disrupt cell division, making them effective chemotherapy agents. The main groups include anthracyclines, chromomycins, and a few others like bleomycin, mitomycin C, trabtidin, and ixabepilone. Let's break down each group and see what makes them unique. Start with the anthracyclines, perhaps the most well-known drugs in this class. This group includes doxorubicin, daunorubicin, epirubicin, idarubicin, and mitoxantrone. Anthracyclines are especially effective in treating solid tumors such as breast, thyroid, ovarian, bladder, and lung cancers, though they have a more limited role in leukemias. Their main mechanism involves intercalating between DNA base pairs, which blocks both DNA and RNA synthesis. Often they're paired with topoisomerase II inhibitors to boost their effectiveness. Anthracyclines do more than just block DNA and RNA synthesis. They also generate quinone-type free radicals inside the cell. This free radical generation is a double-edged sword. It helps kill cancer cells but also brings carcinogenic and mutagenic risks. These drugs are most active during the S phase of the cell cycle, while their greatest toxicity is seen in the G2 phase. Understanding this mechanism is key to appreciating both their effectiveness and their risk. Most important adverse effect to remember with anthracyclines is cardiotoxicity. This stems from the quinone-type free radicals, which cause oxidative stress that the heart is particularly sensitive to. Acute cardiotoxicity can appear just a few days after dosing, with reversible ECG changes, arrhythmias, or hypotension. More concerning is chronic cardiotoxicity, which can lead to progressive cardiomyopathy and even congestive heart failure. The risk increases with cumulative dose, especially above 250 mg/m2 of doxorubicin equivalent. Oncology practice has evolved to better protect the heart during anthracycline therapy. Today, clinicians assess left ventricular ejection fraction (LVEF) before starting treatment and use advanced tools like global longitudinal strain and cardiac troponin to detect early heart injury. For high-risk patients or those receiving high cumulative doses, strategies like dexrazoxane, liposomal doxorubicin, and continuous infusion schedules are considered. These advances help patients receive effective doses while minimizing heart damage. Anthracyclines, like many chemotherapy agents, can cause bone marrow suppression, hair loss, and mucositis with nausea and vomiting. A unique but harmless side effect is red-orange urine discoloration, which can alarm patients if they're not warned in advance. These drugs are also vesicants, meaning they can cause serious tissue damage if they leak outside the vein during infusion. Careful IV monitoring is essential to prevent extravasation injury. Idarubicin and mitoxantrone are two anthracycline-related drugs with distinct features. Idarubicin is less cardiotoxic than doxorubicin and is often used with cytarabine for acute myeloid leukemia. Mitoxantrone, also less cardiotoxic, doesn't generate free radicals in the same way but can still cause cardiomyopathy and bone marrow suppression. A unique side effect of mitoxantrone is blue-green discoloration of the eyes and nails, which is important to mention during patient counseling. Next, let's look at the chromomycins, specifically dactinomycin, also called actinomycin D, and mithromycin. Dactinomycin causes single-strand DNA breaks and blocks RNA transcription. It's especially important in pediatric oncology, used for Wilms tumor and rhabdomyosarcoma. Side effects include stomatitis, diarrhea, skin erythema, hair loss, and bone marrow depression. Mithromycin is less commonly used but shares similar mechanisms and toxicity. Bleomycin is a glycopeptide antibiotic with strong anti-tumor activity. It works by chelating copper and iron, generating superoxide free radicals that break DNA strands. Bleomycin is a cornerstone in testicular cancer treatment, especially as part of the BEP regimen with cisplatin and etoposide. The most important toxicity to remember is pulmonary fibrosis, which is dose-limiting and requires careful monitoring. Mucocutaneous toxicity is also common. Mitomycin C is a highly toxic antibiotic that acts like an alkylating agent once inside the cell. It's used systemically for anal cancer and can be administered directly into the bladder for bladder tumors. Its main toxicities involve the gastrointestinal tract and bone marrow, and because of its potency, doses are usually spaced about 6 weeks apart. This careful scheduling helps manage its risks while maintaining effectiveness. Let's quickly recap the main points. Doxorubicin and daunorubicin are go-to anthracyclines for breast, lung, ovarian cancers, and lymphomas. Watch for heart toxicity. Idarubicin is paired with cytarabine for AML and is gentler on the heart. Mitoxantrone is also used in AML and is known for blue-green discoloration. Dactinomycin is the pediatric tumor drug with bone marrow depression as a key risk. Bleomycin is essential for testicular cancer with pulmonary fibrosis as the main concern. Mitomycin C is used for anal and bladder cancer with GI and marrow toxicity. Anti-tumor antibiotics have been foundational in oncology for decades. Despite advances in targeted therapies and immunotherapies, these drugs remain central to regimens for breast cancer, lymphoma, testicular cancer, and pediatric oncology. What sets them apart is the need for close toxicity monitoring, especially for heart and lung risks. The field of cardio-oncology grew largely from the need to manage anthracycline cardiotoxicity, showing how supportive care and pharmacology evolved together. That wraps up our look at antibiotics used in cancer chemotherapy, from DNA intercalating anthracyclines to bleomycin's role in curing testicular cancer. Stay tuned for our next episode, where we'll continue breaking down oncology pharmacology one drug class at a time. This has been Oncoverse. See you in the next episode. Any anti-tumor antibiotics were first discovered as natural products from soil bacteria, particularly streptomyces. This fascinating origin story highlights how nature can provide powerful compounds that, with scientific refinement, become life-saving medicines. The journey from soil to chemotherapy infusion is a testament to the creativity of medical research. DNA intercalation is a process where molecules like anthracyclines slip between the base pairs of DNA. This disrupts the structure of the DNA helix, blocking the machinery that copies and transcribes genetic information. For cancer cells, this means they can't divide or survive, making intercalation a powerful anti-cancer strategy. Topoisomerase II is an enzyme that helps untangle DNA during cell division. Anthracyclines interfere with this enzyme, further preventing cancer cells from replicating. Combining anthracyclines with topoisomerase II inhibitors can enhance the anti-tumor effect, making this a common strategy in chemotherapy regimens. Anthracyclines generate quinone-type free radicals inside cells. These highly reactive molecules damage cellular components including DNA, proteins, and membranes. While this helps kill cancer cells, it also explains why these drugs can be carcinogenic and mutagenic, and why they pose risks to healthy tissues, especially the heart. Anthracyclines are most active during the S phase of the cell cycle, when DNA is being synthesized. However, their greatest toxicity is seen in the G2 phase, just before the cell divides. This cell cycle specificity helps explain both their effectiveness and their side effect profile. Acute cardiotoxicity from anthracyclines can appear within just a few days of dosing. Patients may experience ECG changes, arrhythmias, or low blood pressure. Fortunately, these effects are often reversible if caught early, highlighting the importance of close monitoring during treatment. Chronic cardiotoxicity is a more serious concern with anthracyclines. Over time and with higher cumulative doses, patients can develop progressive cardiomyopathy, which may lead to congestive heart failure. This risk underscores why cumulative dosing is carefully tracked and why cardiac monitoring is so important in oncology practice. Risk of anthracycline-induced heart failure increases significantly at cumulative doses above 250 mg/m2 of doxorubicin equivalent. Beyond 550 mg/m2, the risk rises even further. Oncology teams use these thresholds to guide dosing decisions and to determine when to implement additional cardioprotective measures. Before starting anthracycline therapy, patients undergo a baseline assessment of left ventricular ejection fraction, LVEF. This test measures how well the heart pumps blood and helps identify those at higher risk for cardiotoxicity. Ongoing monitoring during treatment helps catch problems early, allowing for timely interventions. Newer tools like global longitudinal strain on echocardiography and cardiac troponin levels can detect heart injury even before LVEF drops. These advances allow clinicians to intervene earlier, reducing the risk of long-term heart damage and improving patient outcomes. Dexrazoxane is a medication used to protect the heart during anthracycline therapy. It works by interfering with anthracycline binding to topoisomerase II beta, reducing both cardiotoxicity and the risk of heart failure. It's especially considered for patients at higher cumulative doses or with pre-existing cardiac risk factors. Liposomal formulations of doxorubicin encapsulate the drug in tiny fat bubbles, which helps reduce its cardiotoxicity. These formulations allow for more targeted delivery to tumors while sparing the heart, making them a valuable option for some patients. Administering anthracyclines as a continuous infusion rather than a single bolus dose can lower the risk of peak cardiotoxicity. This approach spreads out the exposure, reducing the stress on the heart and improving the safety profile of these drugs. Bone marrow suppression is a common side effect of anthracyclines and many other chemotherapy agents. This can lead to low blood counts, increasing the risk of infections, anemia, and bleeding. Regular blood tests are essential to monitor and manage these risks. Hair loss, alopecia, and mucositis inflammation of the mouth and gut lining are well-known side effects of anthracyclines. While distressing, these effects are usually temporary and reversible after treatment ends. Supportive care can help manage symptoms and improve patient comfort. A unique feature of doxorubicin is that it can turn urine red-orange. This harmless side effect can be alarming if patients aren't warned, so it's important for clinicians to mention it during counseling. Knowing what to expect helps reduce anxiety and builds trust. Anthracyclines are vesicants, meaning they can cause severe tissue damage if they leak outside the vein during infusion. This is called extravasation. Careful IV site monitoring and prompt action if leakage occurs are essential to prevent serious complications. Idarubicin is often used with cytarabine as induction therapy for acute myeloid leukemia, AML. Its lower risk of cardiotoxicity compared to doxorubicin makes it a preferred choice in some regimens. This combination has become a standard in AML treatment protocols. Mitoxantrone, while less cardiotoxic than classic anthracyclines, can still cause heart and bone marrow problems. Its most distinctive side effect is blue-green discoloration of the eyes and nails. This unusual effect is harmless but important to mention so patients aren't surprised. Dactinomycin, or actinomycin D, is especially important in pediatric oncology. It's a key drug for treating Wilms tumor and rhabdomyosarcoma in children. Its main side effects include bone marrow depression, stomatitis, diarrhea, skin erythema, and hair loss. Mitomycin is another chromomycin with similar mechanisms to dactinomycin, but is less commonly used today due to its toxicity profile. It's a reminder that while some drugs have fallen out of favor, their study has contributed to our understanding of anti-tumor antibiotics. Bleomycin is a cornerstone of the BEP regimen for testicular cancer, combined with cisplatin and adiposide. This combination has dramatically improved cure rates for testicular cancer, making bleomycin an essential drug in this setting. The dose-limiting toxicity of bleomycin is pulmonary fibrosis. This risk means that cumulative bleomycin dose and lung function are closely monitored throughout treatment. Early detection of lung problems allows for dose adjustments and better patient outcomes. In addition to lung toxicity, bleomycin often causes mucocutaneous side effects such as skin changes and mouth sores. These effects are usually manageable but can impact quality of life during treatment. Supportive care measures are important for symptom relief. Mitomycin C has a unique application in bladder cancer where it's administered directly into the bladder intravesical therapy. This local approach targets tumors while minimizing systemic toxicity, making it a valuable option for superficial bladder cancers. Systemically, mitomycin C is used in anal cancer treatment. Its high toxicity means doses are spaced out typically every 6 weeks to allow the body time to recover. This careful scheduling helps balance effectiveness with safety. The main toxicities of mitomycin C involve the gastrointestinal tract and bone marrow. Patients may experience nausea, vomiting, diarrhea, and low blood counts. Regular monitoring and supportive care are essential to manage these risks. Help you remember, here's a quick summary. Doxorubicin/daunorubicin, watch for heart toxicity. Idarubicin, AML, less cardiac risk. Mitoxantrone, AML, blue-green discoloration. Dactinomycin, pediatric tumors, bone marrow depression. Bleomycin, testicular cancer, pulmonary fibrosis. Mitomycin C, anal bladder cancer, GI and marrow toxicity. Supportive care in oncology has advanced alongside chemotherapy. Cardio-oncology, for example, grew out of the need to manage anthracycline cardiotoxicity. Today, better monitoring and protective strategies allow patients to receive effective doses more safely, improving both survival and quality of life. As cancer treatment continues to evolve, anti-tumor antibiotics remain a cornerstone of many regimens. Ongoing research aims to refine their use, reduce side effects, and develop new protective strategies. Staying informed about these advances ensures the best possible care for patients.